swallowed and had something go down the wrong way? If you have, you may have some idea of what it's like to have dysphagia. Dysphagia is, very simply, difficulty chewing or swallowing. Causes include conditions and disease states such as poor dentition, stroke, neurological or muscular disorders such as Parkinson's disease or multiple sclerosis, cancer or radiation treatment of the head, neck, or esophagus, or trauma to the esophagus, larynx, or pharynx. Approximately 6 to 15 million Americans are affected by dysphagia, including 53 to 74% of nursing home residents, 14% of hospital patients, and 33% of rehabilitation center patients. Dysphagia can have a dramatic impact on nutritional status, causing potential for malnutrition, dehydration, weight loss, aspiration pneumonia, and depression. To understand dysphagia, it is helpful to first understand the normal swallow, which includes 4 phases: the oral preparatory phase, the oral phase, the pharyngeal phase, and the esophageal phase. Phase 1, the oral preparatory stage, includes anticipation of eating. It occurs before swallowing actually begins. The appearance and aroma of the food stimulate the mouth to water, producing saliva, and the stomach begins to rumble as it produces acids in anticipation of eating. This stage of the swallow also includes biting, chewing, and forming a food bolus. Phase 2. The oral phase is a voluntary action of moving the bolus to the back of the mouth to be swallowed. The ease or difficulty of this stage is affected by food temperatures, textures, and moisture. Phase 3. In the pharyngeal phase, the swallow response is triggered involuntarily when the food bolus reaches the back of the throat. This causes a sequence of motions that moves the bolus into the esophagus. Normally, the larynx lifts and closes to protect the airway. This action takes less than 1 second. Temperature, taste, and texture of the food can affect the response speed of the swallow. The viscosity of liquids can affect the speed at which liquids move in the throat. Usually thin liquids move faster than thick liquids. Phase 4. The esophageal phase includes the involuntary movement of the food from the upper esophagus to the stomach. In the normal swallow, this takes about 9 seconds. For the person with dysphagia, problems can occur at any one of the 4 phases of swallowing. There may be a delayed, incomplete, or absent swallow response. If the sequence doesn't occur completely or is mistimed, the patient is at risk for aspiration. Oral dysphagia may be diagnosed in a person who has difficulty initiating a swallow due to difficulty chewing, difficulty manipulating food in the mouth, or propelling food to the back of the throat. Pharyngeal dysphagia may be diagnosed when the bolus of food or fluid penetrates the larynx. This may be due to a delayed swallow reflex, incomplete closure of the larynx, or residues remaining in the pharynx after the swallow. The danger here is that it may cause aspiration. Esophageal dysphagia may be diagnosed if food is unable to move through the esophagus easily. This can be caused by poor motility through the esophagus, a blockage such as a tumor, stenosis of the esophagus, or strictures due to gastroesophageal reflux disease, GERD. When working with people who are at risk of dysphagia, it is important to know the warning signs of dysphagia. Warning signs include poor dentition, sore mouth or gums, or poor mouth care. Taking a long time to begin a swallow. The need to swallow 3 to 4 times with each bite of food. Coughing and or frequent throat clearing before, during, or after a swallow. Wet, gurgly voice. Pocketing food in the mouth. Difficulty controlling liquids or mouth secretions. Spitting food out. Extremely slow eating unrelated to a self-feeding disability. Rocking the tongue back and forth front to back. Repeated upper respiratory infections, or recurring or persistent pneumonia. Persistent low-grade fever. Fullness or tightness in the throat or chest, or sensation of food sticking in the throat or sternal area. Referral to the dysphagia care team. Patients who display any of the previously mentioned warning signs should be referred to the dysphagia care team. The physician, speech-language pathologist, SLP, nurse, and dietetics professional. The dysphagia team will assess for specific problems and determine appropriate treatment for the individual. They may ask the patient questions such as, are you having any difficulty swallowing? Are liquids hard for you to swallow? Do you feel like food is stuck in your throat or chest? Do you need to clear your throat frequently? Do you have a wet, gurgly, or hoarse-sounding voice? Do you feel a need to swallow 3 or 4 times per bite of food? Do you cough before, during, or after swallowing? Have you had any recent changes in eating habits? Have you had any recent weight loss? Treatment goals for dysphagia include prevention of choking and aspiration, promotion of healthy nutritional status and weight, encouragement of independence with eating, increased enjoyment of eating and quality of life. A dysphagia treatment plan usually includes safe swallowing techniques and food fluid consistency alterations to assist the patient in creating a food bolus more easily. The primary objectives of treatment are to make swallowing safer, avoid aspiration, and assure adequate nutrition and hydration. If swallowing is determined to be very high risk, an enteral tube feeding may be recommended. However, many patients can be treated by altering food fluid consistencies and by working with the SLP on safe swallowing strategies. The SLP may teach the client to compensate for a weak swallow with techniques such as using a chin tuck swallow, proper positioning, adaptive equipment, and using cold foods or liquids at the beginning of the meal or interspersed during the meal to stimulate the swallow. The dietetics professional develops a nutrition plan with proper food and liquid consistencies and helps to create a positive environment free of distractions for dining. Positioning for eating. Proper positioning is extremely important for a safe swallow. When positioning a dysphagia patient to eat or drink, it is best to seat them in a dining room chair with arms and follow these guidelines. 1. Small of back to the back of the seat with the torso at a 90-degree angle to the lap. 2. Upper legs at a 90-degree angle with the lower legs. 3. Feet on the floor with the lower legs at a 90-degree angle to the feet. And most importantly, 4. Head held so that the chin is at a 90-degree angle with the torso. It is most important to try to achieve a 90-degree angle with the chin to the torso. Tip your head back and swallow. It's harder to swallow with your head tipped back, isn't it? A nosy cup, which is a cup with the side cut out for the nose to fit in to keep the head from tipping back, may be helpful for individuals with dysphagia when drinking liquids. Straws may be unsafe for individuals with poor mouth control, as they may suck too hard on the straw and propel the liquid to the back of the throat too quickly, causing the possibility of choking and/or aspiration. The services of the SLP physical therapist and occupational therapist may be helpful to achieve the best positioning and for strategies for safe swallowing. It is extremely important to work with the SLP on positioning that is appropriate for the individual patient. Techniques mentioned here are not appropriate for everyone. They must be individualized to assure the best interventions for each person. Good oral hygiene after eating is essential to remove any food debris from the mouth. Individuals with dysphagia should remain upright for 30 to 60 minutes after a meal to reduce the incidence of aspiration. The head of the bed should be elevated at least 6 inches or 30 degrees at all times to reduce the risk of aspiration. Dysphagia diet textures. All foods and fluids should be easy to swallow and served in an appetizing manner to encourage eating. Foods may need to be soft, chopped, ground, or pureed. Moist foods that hold together are easier to control and easier to swallow. It is important to avoid small particles of dry food, such as dry ground meat, rice, nuts, corn, or peas. Food should be served either cold or hot. Cold food, sour foods, or liquids can help trigger the swallow. The National Dysphagia Diet Task Force, a group of registered dietitians, SLPs, researchers, and industry leaders have developed a nationally standardized definition for food and fluid consistencies for dysphagia treatment. They have defined 4 diet levels. Level 1, dysphagia pureed. Level 2, dysphagia mechanically altered. Level 3, dysphagia advanced. Level 4, regular. Level 1 is the dysphagia pureed diet. It is food that is in the form of an easy-to-swallow bolus, pureed, cohesive, and pudding-like consistency without particles. It provides a nutritionally adequate, easily swallowed diet with minimal chewing. Level 2 is the dysphagia mechanically altered diet. It is cohesive, moist, semi-solid food that requires some chewing, but forms easily into a cohesive bolus. It excludes most bread products, crackers, and other dry foods. Level 2 diet consists of moist, ground, soft-textured, minced or fork mashable, simple-to-chew foods that are included in a transition from puree texture to mechanical soft texture. Level 3 is the dysphagia advanced diet. It includes soft, solid foods that require more chewing ability. Level 3 consists of easy-to-cut meats, fruits, and vegetables in soft, bite-sized pieces. It is regular texture foods with the exception of hard, chunky food items. All foods in Level 1 and 2 are allowed. It excludes hard, crunchy fruits and vegetables, sticky foods, very dry foods, breads, dry cereal, crackers, dried baked potatoes, fried potatoes, hash browns, peanut butter, hard cheese, seeds, nuts, coconut, dried fruits and vegetables with hulls. Level 4 is the regular diet, which includes any solid textures. When determining the proper level of dysphagia diet, it is important to encourage the highest texture safely tolerated by the individual. If an individual can handle a Level 2 or 3 diet, it is preferable to Level 1 pureed diet, simply because the goal is to keep the individual at the highest level safely tolerated. The physician, SLP, and the dietetics professional will determine the best level for each individual. Making the consistency altered diet appealing. Mechanically altered diet should be served on china dishes just like all other diets. It is best to avoid divided dishes unless a patient needs a divided dish to enhance independence in eating. Plate presentation is extremely important. Keep foods moist to assure they are easy to swallow. Always serve ground foods with a gravy, sauce, or mayonnaise. Always identify meats for the individual you are serving. Try individual casserole dishes. Be sure chopped foods are appropriate size and are well tolerated. Contrast colors of foods and sauces, and garnish foods as appropriate. The pureed diet is generally described as moist mashed potato or pudding consistency. Food must be pureed in a food processor in order to obtain a smooth and easy-to-swallow product. The pureed diet should look and taste like the regular diet as much as possible, while achieving the appropriate consistency of pudding or moist mashed potato. Standardized pureed recipes will assure consistent quality, flavor, appearance, consistency, and nutritional content. Here are a few suggestions that can help to make pureed food look more appealing. Always serve meats with sauces and gravies. Flatten a scoop of pureed meat with a spatula to make a patty. Make meatballs using smaller scoops, number 20 or 24 of pureed meat. Fruits or desserts can be garnished with colored gelatin powder or whipped topping. A slurry mixture can be created by mixing a modified food starch with a liquid according to the manufacturer's instructions. This slurry mixture can be poured over regular bread products such as cake, cookies, donuts, or bread. The slurry mixture soaks into the bread or cake, moistening the whole item. When it is refrigerated, it creates a gel effect that makes the texture safe to swallow. It's more like a pureed texture, a cohesive, ready-to-swallow food bolus. The best part is that it looks just like the regular product. Mix 2 different colored vegetables, such as peas and carrots, and pipe them through a pastry bag onto a plate to create a more appealing look for vegetables. Serve meats or vegetables or a combination of meat and potatoes in an individual casserole dish, such as shepherd's pie. Serve vegetables with cheese sauce, white sauce, butter, or margarine. Try using shaped food molds to create the appearance of the regular food. Create a sandwich by layering gelled bread with pureed meat. Create a lasagna by layering pureed pasta with pureed meat and sauce. Garnish breads with margarine or jelly, or serve with sauce, butter, or gravy. Serve frozen fruits as sorbet, as tolerated and according to the consistency of liquid that is ordered. Commercial food thickeners and pre-prepared pureed products can allow variety in the pureed diet and help patients feel that they are receiving a more normal diet. Hydration. Liquids may pose problems for patients with dysphagia because thin liquids tend to be the most difficult to swallow. It is important to work with the SLP to provide the safest type of liquid for each individual to swallow. Most adults need about 6 to 8 of 8-ounce cups of fluid per day. Thickening liquids will slow down the movement of the fluid from the mouth through the esophagus to decrease the risk of aspiration. The National Dysphagia Diet Task Force has defined liquid consistencies as thin, nectar-like, honey-like, spoon-thick. Thin liquids are those with a low viscosity such as water, tea, coffee, soda, clear juice, broth, thin vegetable or tomato juice, watermelon, plain gelatin, milk, supplements, ice cream, frozen yogurt, or anything that will liquefy in the mouth within a few seconds. Nectar-like liquids have a medium viscosity, such as nectars, such as peach, pear, or apricot, thicker vegetable juices, liquids thickened with commercial products to achieve a nectar consistency, pre-prepared thickened commercial products for nectar-like consistency, such as milk, juice, water, or iced tea. Honey-like liquids are the viscosity of honey and include liquids that are thickened to honey consistency using commercial thickeners to achieve this consistency, and pre-prepared thickened honey-like consistency commercial products. Spoon-thick liquids are the consistency of pudding. It is difficult to achieve hydration at this level of thickness because it is hard for the dysphagia patient to consume the needed amount of liquid to remain hydrated. In addition, the flavor and mouthfeel of the original liquid may be altered to a point that is less appealing. Liquids can be thickened using modified food starch thickeners or gel thickeners. Pre-thickened liquids are used by many facilities to reduce the potential for incorrect thickness of a liquid. Preventing malnutrition and weight loss. Dysphagia patients are at risk of malnutrition and dehydration, so it is important to provide appealing foods and fluids at the appropriate consistency level and encourage food and fluid intake. Summary. Dysphagia can make eating and drinking a difficult task. By following a few simple steps, we can help to improve quality of life for dysphagia patients. Watch for early warning signs of dysphagia. Refer potential problems to a supervisor, physician, SLP, and/or dietetics professional. Follow through on appropriate strategies to make it easier to swallow, appropriate food and fluid consistencies, positioning and feeding techniques as prescribed. Provide appealing foods and fluids by following recipes and shaping or garnishing foods for better eye appeal. And most important, provide encouragement and compassionate care.
And if you're the one with the dual diagnosis, be kind to yourself. Depression is not your fault. But as they say in AA, recovery is your responsibility.